Good morning, everyone. Why don't we go ahead and get started since we have a nice quorum and people will still be trickling in. So my name is Darshan Mehta. I'm the medical director of the Benson Henry Institute for Mind Body Medicine and director of education for the Osher Center for Integrative Medicine here at the Brigham. Before I introduce speakers, just a couple of housekeeping announcements. One is that we'll have immediately following this presentation, we have a coffee hour just across the hall in that little lobby in the 45 Francis Street atrium. And so please join us to continue the discussion, which I already know will be quite lively coming out of this one. So please join us for that. Second, as some of you know, we have a fellowship, a postdoctoral T32 fellowship in complementary integrative medicine that's funded through the National Center for Complementary Integrative Health at NIH under the direction of Dr. Gloria Ye, who's our Associate Director of Research for the Osher Center. And so we are still inviting applications. So if any of you or have up-and-coming postdocs, that includes MDs, PhDs, and other doctoral degrees, they're eligible to apply. Please come talk to myself or Atra, and we can link you to the right people for that. But the applications for that will be due October 1st for those of you, if you have people that might be interested, or if you yourself are interested. And then last, our grand rounds are held, as you know, on the first Tuesday of every month here at Bornstein at 8 a.m. Next month, because of the holiday, we're going to be our grand rounds will be on Tuesday, September 10th. So it is just an alteration just because of the Labor Day holiday. And our topic will be neuromodulation in tune with body's rhythms, enhancing clinical outcomes with respiratory-gated auricular vagal afferent nerve stimulation. This will be given by Dr. Vitaly Napadau, who's based at the Martino Center at Mass General. So our grand rounds, as many of you who have been here regular attendees, alternate between a clinical case conference and a research-focused conference, although all of them really, we try to really imbue them with research, latest experts, and sort of what is the emerging trends in the field. And so with that, we're really excited to have our speakers today, and this discussion will be led by Dr. Kim Parks, who is the medical director of Synergy Private Health, staff cardiologist at MGH and Wellesley Hospital, and Dr. Deepak Bhatt, who is the executive director for interventional cardiovascular programs, Heart and Vascular Center here at Brigham Women's Hospital. These are really eminent thought leaders, and we're really, really excited to have both of them. Just a quick story. I met Dr. Parks, I want to say now probably about 7 or 8 years ago, when I was sort of new at Mass General and wanted to learn about what services stress reduction can be offered. And she was at that time running the heart transplantation service at Mass General. So it's been quite a wonderful reconnection to see this evolution into culinary medicine. And today's topic will be entitled Cardiovascular Interventions on a Fork, Changing Outcomes in Culinary Medicine.
Thank you for that kind introduction, and thank you all for attending today. And for those of you who are online as well, we'd be happy to field some of your questions. So I'm going to start with something practical. I'm going to show you some of the tools that I use in my practice now. As Dr. Mehta mentioned, in my previous career, I used to implant left ventricular assist devices and give people heart transplants, et cetera. And now the tools that I use in my office look like this. So I'm just going to show you how simple it is for you to incorporate a culinary medicine and practice in your own office. You don't need a fancy kitchen. This is a induction top that we got at a restaurant supply store. And I'm going to cook some whole grains. A lot of our patients don't actually know what a whole grain is. This is farro. It's been rinsed. There's 1 cup in here. And what we teach people is how to simplify bringing healthful foods into their lives. So I'm going to kind of multitask because that's what we do and that's what most of our patients do. So on a Sunday, they can just cook some whole grains on the stove while they're answering email or doing other things, and then they can freeze it for later. So I have Caitlin Peters. She's a nurse practitioner and health coach at our practice. So she's going to be keeping time on this, and she'll be up here making sure that we don't overdo it here. So this is just 1 cup of grains and 1 cup of water. And when we're finished, Dr. Bhatt is going to demonstrate how to implant a coronary stent live up front here. All right, and that should start boiling in just a moment. All right, so my only disclosure is that I do own a culinary medicine program. Just to provide you an overview with what we'll be talking about over the next hour. We're going to present a case. We'll talk about the scientific evidence supporting the major impact of dietary patterns on health outcomes. We'll talk about specific mechanisms of how foods can impact coronary heart disease risk. And we'll also talk about data supporting culinary medicine and how it can be used. I am very grateful to Bruce Rodman, who's in the audience today, and he is going to be our featured patient and case. So he will talk a little bit about his experience, and Dr. Bhatt will highlight traditional management of cardiac disease, and then we'll have a panel discussion. But let's start with anatomy. All right, so we're going to give you an anatomy lesson on a grain, right? Because carbohydrates have a bad name. Right? Don't eat carbs. And the problem is most of the carbs that we're exposed to is through breads and processed foods. And so whole grains are actually very healthful. They are full of nutrients, and they have 3 components: a bran, a germ, and an endosperm. And you can see that the germ is the nutrient storehouse, and the bran protects the seed and has lots and lots of fiber. And the endosperm basically just is your carbohydrate source. So what happens when we make white flour or refined flours, and the grain is milled and ground? Well, the brain and the germ are extracted, and all you get is the endosperm. So basically, you're getting a huge load of carbohydrate without the benefit of the nutrient storehouse and the fiber. So we teach our patients this, and we tell them to look for this whole grain seal that you see that guarantees that you're not being duped by some of the labels that we see in our packaging. So let's start with a quote: "The doctor of the future will no longer treat the human frame with drugs, but rather will cure and prevent disease with nutrition," said by the good Thomas Edison. So let's now talk about disease. We're going to start by talking about Bruce, who you'll hear from in a moment. He came to me less than a year ago. He's 62, active gentleman. He presented to established care for management of what had been diagnosed as paroxysmal atrial fibrillation. He also has hypertension and pre-diabetes. His only surgical history is shoulder surgery. He is happily married to his high school sweetheart and has 2 successful grown children. He does have a high-stress job as a local business owner. He's a lifetime non-smoker, only drinks alcohol on occasion, and he loves to exercise. He exercises regularly on a spin bike. He does have a history of premature coronary disease in his family, and his mom, who had an MI before the age of 60, although she is alive and well at age 91. And he tells me at the visit that he had occasional palpitations associated with his paroxysms of AFib. And he also said, I did notice a little bit something weird in my chest a few months ago when I was cycling, but you know what, I haven't had any recently. And otherwise, he was without any complaints. After the visit, he did call and say, there was one thing I didn't tell you about, and that was I was out dancing with my wife while I was vacationing, and I had some exertional chest discomfort, which makes all cardiologists get a little nervous. His medications are as you see here. And vital signs are unremarkable, and his cardiac exam was normal. So, Bruce, why don't you come on up and tell us up to this point, before you saw me, what your interactions had been like with physicians. And you can actually just grab one of these mics here. Test. Okay, there you go.
Hi, thank you, Kim. Pleasure to be here, literally. My experience with physicians prior to meeting Kim was more traditional. It was Whatever your symptoms are, we have a medication for that. And unfortunately, the medications have side effects. And basically, I was presenting with hypertension, insomnia, pre-diabetic, and generally fatigued. I wasn't able to exercise and withstand the workout. I took a few days to recover, so I had lots of complaints, and I felt like I was a hypochondriac with my doctor, but it seemed that everything I complained about there was a medication for, and I kind of became a little bit hesitant about this. So, I mean...
And just quickly, did anyone ever talk to you about lifestyle and diet?
Well, diet. But
what was that conversation like?
Just about losing weight. I mean, it didn't really involve what I should be eating, and the exercise was something that was almost a given. Everyone should be exercising, but it wasn't a program of any kind. And when it came to diet, it was basically something that a nutritionist would do, and he talked about seeing one, but I never did.
Great. All right. And I'll just point out that I think most of you in the audience would agree that Bruce doesn't look like a typical patient. He is not morbidly obese. He doesn't have any signs or symptoms of being in poor health. But this is typical. I mean, this is what we see in our office every day. It's not the typical, severe diabetic, overweight, et cetera. So when we talk about diet, it's not focused on weight management. It's about health management. Great, thanks. So we sent Bruce off for a coronary CT angiogram, which suggested that he had coronary artery disease, and then he did go on to have a cardiac catheterization, and we're just going to have fun here and show. Many of you in the audience may have never seen a heart catheterization, so we'll just give you a nice drive through that. So I think Dr. Bhatt is just going to show us.
Welcome. And I just want to say I wasn't actually involved with this case or procedure, so I just saw this for the first time this morning. But what this is a coronary angiogram, so an invasive procedure taking a look at the heart arteries. And these are the arteries to the left side of the heart. This is what's called right here the left main coronary artery. This is the artery to the front of the heart, the LAD. And the artery to the left side of the heart is shown right here, the left circumflex. And this tube up here is a catheter that's injecting contrast dye. So you could basically pretend that the black is blood. It's actually contrast, iodinated contrast, but that's the blood flowing through the heart. And then several views are taken because this is a two-dimensional image, but in our brains, when we're doing these procedures, we're reconstructing in 3D what's going on. So here's the left main coronary artery and the artery to the front of the heart. And there's, as the CT angiogram said, a moderate degree of narrowing here in the middle part of the artery. And then several other views just basically showing disease in different branches, again, moderate to moderately severe. And then there's this middle branch here. Some people would call it a ramus, maybe a bit more technicality than we need for this morning, but that has a severe narrowing there. So lots of different areas of moderate to moderately severe narrowing. And some more views of those arteries. And now's the artery to the right side of the heart. So flipping over to the other side of the heart, a different catheter up here going in to the heart artery selectively, right at its origin. And right here you might see a discontinuity. So the blood is the black. That's nice blood flowing down to the heart muscle, supplying it. But right here in the middle, there's an empty space here, so that's 100% blockage. And you might say, oh, wow, how did he survive that 100% blockage? I would say probably good luck, because if that had occurred suddenly, and if nature hadn't formed a bypass here, collaterals, there wouldn't be this blood flow down here. That would result in a heart attack, and in people that are unlucky, that can be out-of-hospital cardiac arrest or sudden cardiac death. But when people are lucky, when a blockage forms, it forms slowly over time, and nature bypasses the blockage. So this is a nice result in terms of staying alive. And when it doesn't happen, that's when people run into trouble with heart attacks, including dying from them.
Great, thank you. All right, so we'll dive into the traditional approach to management of the patient with coronary disease a little bit later, but this is just sort of a summary slide here. And in Bruce's case, the best traditional management option was surgery. So he did undergo coronary bypass surgery in January of this year. So he'll talk about that experience in a little bit. But typically, there's a whole cocktail of medications that we give patients to make sure that they, to improve their mortality long term. And it includes antiplatelet agents, statin medications, beta blockers, ACE inhibitors, cardiac rehab. And we do talk about lifestyle interventions, but I would submit that that's one of the areas where we could actually do a lot better and maybe have a greater impact on our patients. So now we're going to talk about how food can really be a powerful medical tool. Food is the great equalizer. It's a great way to relate to your patients. We all have to eat, and our choices directly determine how we feel, how long we live, and how we die. And I'm going to show you some of the evidence behind that. And when it comes to cardiovascular disease, I know for me in fellowship, I always thought about diet and cholesterol and, eat low fat. And that was sort of, my growing up. We told everybody to eat low fat. And what happened is we all got fat and we got more sick with coronary disease. And what we can learn from studies on public health and food is that what we don't eat may actually be a more powerful predictor of health or disease than what we do eat. So the important message may not be don't eat the donut, but eat more apples and forget about even talking about the donut. So there is a public health crisis, and I'm going to show you the data behind it. But this is a familiar photo, right? It's hard to go out anywhere and not see the items that you see on the screen. But as it turns out, food is the #1 cause of poor health in the United States, and not just in the US, but worldwide. Our society of convenience has led us more quickly to our graves. And in fact, poor diet is the leading cause of death and disability. Suboptimal diet is associated with many chronic diseases, and nearly 50% of deaths related to cardiovascular disease, stroke, and diabetes is related to poor diet. So let's look at the number of deaths that were related to the 17 leading risk factors in the United States. And think about, what do you think when you think about risk factors that can be prevented, right? We think about all the things we talk about: tobacco, blood pressure, obesity, et cetera. But as it turns out, the #1 risk factor related to death is dietary risk. Right up here on top. It surpasses tobacco, it surpasses obesity, and quite certain you can't see these, the small print, so I'm going to define this for you. But dietary risk here is at the front, leading to 700,000 deaths per year in the United States. And this blue bar here represents the disease state that's most closely associated with dietary risk. And that blue bar stands for cardiovascular disease. Now, if we look at worldwide data and we look at what specific parts of our diet are actually leading to death, #1, diet high in sodium. Again, this is worldwide. I'm going to show you some US data as well. And then the only word high is at the top here, sodium. Everything else is diet low in whole grains, diet low in fruits, low in nuts, low in vegetables, low in seafood omega-3s, low in fiber, low in polyunsaturated fatty acids, low in legumes. All right, so, we tend, I know my previous conversations with patients were to avoid specific foods, and I've changed my conversation now to talk about the foods that they need to incorporate in their diet. And here are some data from a recent article in JAMA that looked at specific foods. This is U.S. population that were responsible for diet-related death. And #1 on the list, well, actually it's not #1. High processed meats was actually #1 on the list here, as you can see, followed by high sodium. And processed meats are really quite prominent in the standard American diet. And then, low in seeds and nuts, low in vegetables, low in fruits, low in seafoods, et cetera. Again, you're seeing a pattern here. And here's another paper from our colleagues at the Harvard School of Public Health that looked at various food groups and which ones were more closely related to death. And you can, again, all the data is consistent here. Processed meats having the highest propensity for death, and then refined grains, right? Eating lots of refined grains. The problem is if you're eating refined grains, that's a replacement for whole grains. The more whole grains you eat, the lower your risk of death. That goes for nuts, vegetables, fruits, fish. And then when it comes to dietary pattern, the one that has the highest risk for death here on this list is the Western diet. Within the Western diet, that's also been studied. The Southern diet actually has the highest correlation with death. So this is the SAD, or the Standard American Diet, and this is typical when someone goes out, right? You get this huge piece of meat on a plate, and not a lot else with it. The focus is that. It's the protein, the protein, the protein. And, you know, even when you're giving carbs, you know, there's not much else in there, right? So remember Dave from Wendy's who coined the "Where's the beef?" Remember those commercials? And, you know, they wanted to get more beef in your burger. Well, where are the veggies? Where are the veggies? And the whole grains. So have we reached a new normal in how we think about food? Here's two women out eating. She says, my doctor wants me to reach a normal weight, but if everyone is heavy now, then overweight is the new normal. Well, is it really akin to this? These are real advertisements. You used to be able to go to your doctor and have a cigarette with your doctor. More doctors smoke Camels than any other cigarette. And look, this guy, I've had plenty of experience with different cigarettes during the war. It's Camels with me. I mean, and look at this, 20,000 physicians say Luckies are less irritating, right? It was the normal, yet people were dying. People are still dying. Who benefited? Oh, wasn't expecting that, all right. How about this guy, right? Remember this mascot, Popeye, right? Health promoting foods led to a good life, but this is what we see now. We have Lucky Charms, bigger marshmallows, Tony the Tiger. I mean, this is what we're feeding our children. I bet if you read that label, you wouldn't be able to recognize the names on half of the ingredients list. So is this our new normal? How do we expect our patients to survive in this environment when they go out and this is all they're exposed to, right? Get your man of Steel burger. Starts when we're children. But dietary interventions work. For those of you who were here a couple months ago and learned about the Mediterranean diet, you saw some of this data that showed that one of the initial diet studies on the Mediterranean diet was on patients who were hospitalized, had an MI, and were randomized to either the Mediterranean diet or the standard, really the AHA diet, the prudent diet, reduce your intake of saturated fat and cholesterol. And here's what they saw. First of all, here's your Kaplan-Meier curves, and the impact starts very early on. This is up to 5 years. Here's the experimental group who was on the Mediterranean diet versus the controls. And you can see that in 5 years, there's a 72% reduction in non-fatal MI and death after 5 years. And the number needed to treat is only 18. So, you know, one could argue this is not a robust population, but you can't really argue about the safety of adopting a Mediterranean diet. And here's another one of the landmark trials, one of the really the only large randomized controlled trials using diet, the PREDIMED study that randomized people to Mediterranean diet or standard diet, and there was a 30% relative risk reduction in acute MI, stroke, or death from cardiovascular causes. So when it comes to cardiovascular disease, then what are the foods that, we don't have a lot of data, right? So what are the foods that might help prevent cardiovascular disease? This is a recent study that was just published online looking at the association between plant-based dietary patterns and the risk of type 2 diabetes, which found that high intake of plant-based foods was associated with a 30% reduction in type 2 diabetes, which is one of the leading risk factors for cardiovascular disease. Here's some really interesting information about fruits and vegetable intake. And this study looked at 84,000 women and 42,000 men. They followed them for 8 years and found that for every serving, that should say 1 cup, not 1/2 cup, of dark leafy green vegetables, there was a 23% risk reduction of coronary heart disease, 23%. Another study showing that drinking beetroot juice actually can reduce your blood pressure by 8 millimeters of mercury systolic and 2 millimeters diastolic. And interestingly, when you consume nitrate-rich foods, which beetroot is, the bacteria in our saliva convert nitrates to nitrites and exert their positive effects on the vascular endothelium. And blueberries, as it turns out, this is actually a recent study that fed people 1 cup of blueberries over 6 months and led to improved endothelial function, attenuated cyclic GMP concentrations, and increased HDL. That's just 1 cup of blueberries. You can throw that in a smoothie first thing in the morning and you're done. And, again, thinking about foods that affect the coronary vascular system, here's one of the hypotheses about the gut microbiome. And when we eat red meat in particular, red meat is high in dietary phosphatidylcholine and L-carnitine. And our gut microbiota process that differently than plant proteins, and it produces TMAO, which is one of the newer hypothesized markers in cardiovascular risk. So, it's confusing. One diet told me to eat more fruits, nuts, and grains. Another told me to eat more fish and cheese. Long story short, I gained 40 pounds. We're all very confused, right? So it's estimated that with improved eating behaviors, 1 in 5 premature deaths can be prevented. But we're not talking to patients about this in routine visits, and we're also not receiving the adequate training as physicians to deliver the information. In fact, this study showed that 90% of cardiology fellows said they had no or minimal nutrition education during fellowship training. You just saw the impact. Why aren't we educating our trainees? And doctors are trusted sources of information. Patients say that if they are spoken to about food and diet, 78% will make a change. So one of the proposed ways to intervene is through culinary medicine, which is an emerging evidence-based discipline which aims to positively impact public health by improving eating behaviors through integrating nutritional science with food preparation. The goal is really to reduce the global burden of nutrition-related diseases and reduce healthcare costs. We don't use alternative approaches like specific foods or ingredients as a panacea. Rather, it's an evidence-based approach that includes simple nutrition education and instruction. Instruction, just as we did here. And there's a lot of initiatives right now going on to either clinicians, patients, and communities. There are continuing medical education trainings, formal medical school curricula, outpatient shared visits where you can do these events. All you need is a cooktop here. There's live online courses and remote video courses. Now, to make dietary change, you need not just knowledge, but you need skills. And so, the typical intervention is, I'd like you to eat better. And what happens? Our patients leave and they don't know what to do. We have to teach them, not just go eat more vegetables. Well, if you ask people, what vegetables do you like? Well, a lot of people will say, I don't really like vegetables. So how are you going to get somebody who doesn't like vegetables to start eating them? Or if I say, whole grains will, increase your chances of living longer and decrease your chances of having a heart attack. And I say, what's a whole grain? And people will say, I don't know, quinoa? We literally had someone say that the other day in the office. Is that quinoa? Is that a whole grain? So we don't have to just give patients the information, but we've got to teach them how to do food prep and get them back in their kitchens. You see what they're exposed to outside the home, right? You saw the advertisements. There's an inverse relationship between cooking and mortality, as a matter of fact. And those people who cook more than 5 times per week have a lower mortality. There's a reduced risk of diabetes, higher quality of food intake, and lower quantity of food intake overall. And children who cook at home actually consume healthier diets as well. And we try to simplify food choices for our patients. And rather than, again, telling them what what not to eat, we talk about focusing on the foods that have been proven to have health benefits. So fruits, vegetables, fish, whole grains, legumes, olive oil, and nuts. We say, we don't really know whether these foods in the yellow provide any health benefits, so eat these with caution. And then there are foods that have clearly been shown to cause harm. Clearly. So why are we serving processed meats in our hospital cafeteria? Isn't it kind of like having a cigarette machine? So the current recommendations, back to that, on patients with cardiovascular disease, medications, surgery, stenting, lifestyle interventions. I've shown you some novel cardiac interventions. To your left is a stent. To your right, a proven therapy. On your left, Dr. Bhatt, you were recently the lead investigator on a clinical trial looking at fish oil. Fish get their omega-3s by eating seaweed. Could we just eat seaweed? So in summary, cardiovascular disease is the #1 killer of women and men in the U.S. Dietary factors have a significant correlation with development of cardiovascular disease beyond the traditional viewpoint of cholesterol. There are specific food groups associated with decreased incidence of cardiovascular disease, and creating change in dietary patterns is complex. It requires intervention beyond the office discussion, and culinary medicine is a practice that can be used to help change dietary behaviors. I'm going to put a plug in about a research study that I'm involved in with the chef coaching program through HMS. So if you or anyone, and if you have patients that are interested in losing weight, they cannot be, they have to have a BMI between 27 and 35, and they have to eat out most of the time. We would be interested in talking with them. And there's some flyers about that on the table out there. And this is my kitchen at our office. Not my kitchen, but our patient's kitchen. And here we are doing a cooking class, and you can see it's a collaborative approach. This is a trained chef and health coach, and she's actually toasting some seeds. And we're having a dialogue here about the impact of seeds on health. And here are our students here really getting their hands down. There's a cardiologist in the audience, and there are just some patients, et cetera. And here we are. Look, you see there's the cooktop right there. So here we are learning, and this is some of the delicious food that was prepared that evening. I'm going to also leave you with some resources where you can get further education about culinary medicine and nutrition. At that, I am going to turn it back over to Bruce, and Bruce is going to talk a little bit about... Yep, absolutely. We'll leave that right there. Thank you. Thank you. All right. So Bruce, maybe if you could sort of speak to what was different about your new model of care once you were diagnosed with coronary disease, what that was like for you, and how our approach was a little bit different.
Well, I did mention earlier that the traditional medicine approach for me not only wasn't working, but my side effects from the medications were intolerable.
I'm just going to ask you to put the microphone a little close to you. There.
And when I was introduced to Kim, it was really a whole different approach. It was about
Perfect.
What I was putting in my body. It was about the food. And for someone in the food business, it was all about meat. I'm in the meat business, and between the stress of the work and my diet and my overweight, and I was a real problem when I came. And in fact, the heart disease was the biggest issue that we were fighting right then. So it was all about learning to love food and learn about what I'm putting in my body and what foods actually can help me. I learned from the videos that you gave me and the list of foods to eat that were healthful. that there are good oils out there and fats, and there are good cholesterols in whole grain. And my wife and I learned to shop properly and to read food labels and to do this together and to cook together and to eat out less. So it really was eye-opening to me and an awakening for me to enjoy food in a healthful way.
I'm going to just interrupt there because you mentioned that you started going food shopping with your wife and cooking with your wife, excuse me. And one of the things we talk a lot about in the integrative approach to any disease process is socialization and how important the relationships in our lives are. And so through your process, what I observed is through your process of finding your own health, that actually strengthened the bond between you and your wife because you had this, not that it wasn't already strong, you have a beautiful relationship, but it gave you another common ground, a goal for you both to sort of reach. And instead of going out to a restaurant and just talking about the news, you had a common interest.
Not only that, a life-threatening event and a successful surgery and feeling as though we got a second chance at life. But to have this common bond, to be able to go out and be proactive in our healthful life together, and it went well beyond just the food. And I was taught and helped with my insomnia, how to help myself with that. Coming out of a hospital after quadruple bypass, that's the first thing you have to try and get regulated. But the classes, it was a big social event too. We were inviting people from our residence in Boston to come out to the Synergy Kitchen and to see chefs that like Anna Sortun from Oleana in Cambridge. I mean, this is like, people pay a lot of money to come out to do something like this. And she had, I don't know, Kim, you had about 25 or 30 people there, maybe 40.
So what did you learn from that, Bruce?
Well, she's an amazing top chef cooking healthful foods, a lot of Turkish foods, but the diet, healthy food can be delicious.
Yes.
And that is the biggest thing I learned, that everyone thinks that vegetables are steamed and flavorless. And what we're able to do is combine healthy carbs with great vegetables and seeds. And this is the way the people on this planet eat and live to have very long, healthful lives. And we're learning that these diets, whether it's Indian with the spices, but these are diets that you can introduce by going to Whole Foods and knowing what to be shopping for. And Kim, you also had Sienna Farms at your practice, and they have a farm with vegetables, and you can sign up to have the vegetables every month come to the practice. So this was really opened a whole new world for my wife and I in how to look at food and eating, and to spread your calories out and have something healthful in the morning. And I fell in love with almond milk. So
Great.
All
right, so I'm sure that the audience is going to have lots of questions for you, but right now I'll ask Dr. Bhatt to come up, who's going to talk about the more traditional way of managing coronary heart disease.
All right, terrific. And I'll try to keep things relatively brief just so we have some time for a discussion. Before I get started, here are some disclosures, and in green are potentially relevant ones, just research funding that I received at Brigham and Women's Hospital from various drug and device companies, and I might be discussing off-label or investigational uses of drugs or devices in the course of this talk or the ensuing discussion. So let me just start with a concept. I think all good physicians think about all stages of care that is primordial prevention, which really refers to healthy behaviors, things like fetal and infant health, keeping smoking rates low to non-existent, avoiding high-calorie diets, avoiding physical inactivity, and just aiming for an ideal body weight. Environmental pollution is another sort of risk factor for bad health, including bad cardiovascular health. So primordial prevention is trying to prevent these things from developing, not just in a person, but in society. Then there's primary prevention, which is the treatment of risk factors. So once a person's moved from this phase of their life to this, where there's things like high cholesterol, high blood pressure, diabetes, their lifestyle is also important. But in higher risk people, medications play an important role. And then there's folks that have actual cardiovascular disease, whether it's the heart, the brain, the legs, where there's blockages in heart arteries, or heart failure, where the heart itself is just tiring out and not pumping. And that sort of secondary prevention is where procedures and medications really do have their most important role. Lifestyle is still important, of course, but to an extent, sometimes there more is needed. And, as we're talking about revascularization procedures like stenting and bypass surgery, it's important to talk about what's not controversial. So for people that come in with a STEMI, which is a medical term for heart attack, they're going to the catheterization lab and getting stented. PCI, or percutaneous coronary intervention, is the treatment of choice. There's no debate, there's no discussion. That's someone coming in with a heart attack. That's not the time to pause and say, hey, we need to talk about lifestyle. There you need to act quickly. Time is muscle, and every few minutes counts, and if you wait long enough, that can result in death. So there's no controversy at all. So what we're really talking about is people with stable disease. And even there, in people that have come in with a heart attack, of course, if there's an artery that has a severe narrowing or blockage, we would go ahead and stent that. But if there are other blockages or narrowings in other arteries, should those be stented? A little bit of an area of controversy, though the bulk of data shows, again, that those lesions should be stented. So in people that are having heart attacks or have just had one, that's not what we're talking about here at all. There really isn't much time or room for discussing various options, just need to get the arteries open. What we are talking about is people with stable disease or stable angina, where they've got chest discomfort that occurs with physical activity. And about 20% of stenting procedures are for stable angina. So the vast majority of what we do in the catheterization lab as interventional cardiologists are for people that have heart attacks, chest pain at rest, sort of situations where, again, time matters and there's not often a lot of room or time just to do other lifestyle things in the short term. Can in the long term to prevent that next heart attack, but I'm talking about the treatment of the actual heart attack as it's occurring. And there's different trials. I won't get into the details, but for the most part, we already know that revascularization by stenting, probably by bypass surgery, in people that are totally stable, that don't have diabetes, that have normal heart function, does not affect their future risk of heart attack or death. So the reason to do it is to treat their symptoms. And if we're not treating their symptoms, that is, if they're asymptomatic, it's unlikely that we're going to actually do anything to make them feel better, because they already aren't having symptoms. You can't make an asymptomatic person feel better. Now, there is an ongoing trial to see if you're taking people with stable chest pain and stenting them if they have blockages, whether that does make them live longer. The NIH is funding that trial. That'll be presented at the American Heart Association in a couple of months. I'm a little bit skeptical, but we'll see what the results show. So bottom line, revascularization in a stable person with stable chest pain is rarely done for quality of life reasons, not to make them live longer. It's a common misconception among patients, even among some primary care physicians. Now, in the cath lab, we're always trying to do better and more, and it isn't just a matter of taking pictures, as was shown earlier as I was walking you through those catheterization films. We have fancier techniques of figuring out whether a particular blockage is reducing the flow of blood to the heart muscle or not. One of those is called fractional flow reserve. It's a fancy way of not just taking a picture of a heart artery, that's what I showed you earlier, but taking a miniaturized pressure sensor down across what looks like it's a significant narrowing in the heart artery and measuring the pressure before and after. And of course, going back to physics, if there's a severe blockage, there'll be a pressure drop. And if it is of sufficient magnitude, that correlates with insufficient blood flow to that part of the heart. So bottom line is, if that pressure drop is large enough, you know that that narrowing is actually restricting the flow of blood to that part of the heart muscle served by that artery, and that would be justification for opening it up with a stent, or potentially, if there are multiple blockages, with open heart surgery, bypass surgery. So it's not just a matter of looking at a picture and throwing in stents or doing bypass. And here's an algorithm of at least how I approach patients who have symptoms of coronary artery disease that are stable. Again, these aren't heart attack patients. If they are having unstable symptoms, it's a call 911, go to the emergency department, not a sit around and sort of discuss things. Now, if the symptoms are stable, that's different. The first step is lifestyle management, things like plant-based diet, weight control, regular exercise. Now, that would be first line, but oftentimes the symptoms are going to persist, or if they're symptoms of chest pain, it's hard to say start exercising when they're already having chest pain with walking to the mailbox. So their medicines are needed, and there are two types. There are medicines for risk reduction to prevent heart attack and death, or reduce the risk, can't prevent everything, but reduce the risk of heart attack and death in someone who has suspected coronary artery disease. And that's medicines like statins and aspirin. Great medicines, safe, well tolerated in general, but like everything, there will be some people that will have some side effects. And then there are medicines to treat symptoms. Generic medicines like beta blockers and nitrates aren't going to make that person live longer, but will hopefully let them walk to the mailbox without having chest pain. And then it can be quite useful if their symptoms have resolved, just periodically checking on them to make sure that the symptoms aren't recurring or getting worse, or that there isn't any change in exercise tolerance. Sometimes people say, I'm feeling great, but they're doing less and less, so that isn't really feeling great. But assuming that they are feeling great, then it would be just a matter of continuing medical therapy, no need for invasive therapy at all. On the other hand, if the symptoms aren't better with that first-line intervention with lifestyle and medical therapy, then a stress test can be useful to see if there's a limitation of blood flow, if there's a limitation of physical activity. If someone can't go a couple of minutes on a treadmill, that's a pretty bad sign. Even if they're otherwise out of shape, most people can do that. And if there is evidence of lack of blood flow on that sort of objective testing, well, then that's the time to pursue an invasive evaluation. If not, again, it's still just a matter of continuing medical therapy, reassuring the person that, hey, this test doesn't really show any significant blood flow problem. We can keep doing what we're doing. But if the symptoms are continuing, progressing, then it's time to go on to invasive evaluation. And there are some of the techniques I mentioned, determining whether there's pressure drops, other fancier techniques, can help in the decision of whether to revascularize. And there, whether to go ahead with a procedure sort of depends on what you find. So if there are multiple severe blockages, so-called multivessel coronary artery disease, stenting can be performed, or bypass surgery can be performed. And depends if there are blockages in that main left artery that I showed you. Usually surgery has been performed, though more recent trials show that stenting can be performed with equal success. In people that have multiple blockages in diabetes, studies have shown that bypass surgery likely makes them live longer than a stent approach or just a lifestyle and medical therapy approach. But people that don't have diabetes, that don't have weak heart muscle, but have numerous blockages, there it's actually legitimate to just continue medical therapy, and if they're not having symptoms, stop. But if they're continuing to have symptoms despite best medical therapy, then either a bypass surgery or a stenting approach is reasonable. And a lot of that really depends on the specific patient, their actual coronary anatomy, and whether they're suitable for either stents or bypass surgery. Other medical comorbidities, it's someone who's at a high risk of stroke, you wouldn't do bypass surgery because of its risk of stroke. In someone that has multiple severe total blockages, stenting can be a little technically difficult, you might do bypass surgery. Depends on local expertise. Obviously, if you're having bypass surgery, you want to go to a place that does a lot. And for more complex stenting, you also want to go to a place that does a lot. And personal patient preferences matter a lot in the stable patient with stable symptoms. And there again, medical therapy alone is reasonable, stents are reasonable, and surgery is reasonable. There's not one right answer, and even among physicians, there'll be controversy and debate. So just to conclude then, really the way I view things as far as cardiovascular disease, its prevention, its treatment, is this pyramid of risk. That is, everybody should be doing primordial prevention on an individual level, maybe even influencing things on a societal level to the extent they can, promoting fetal and infant health, trying to ban smoking, trying to encourage physical activity, trying to create environments where people can maintain an ideal body weight, trying to cut down on environmental pollution, and probably the most important thing that each of us can individually influence in our own lives is adoption of a plant-based diet. The next sort of layer up in the pyramid for folks that have risk factors is to treat them with lifestyle, but oftentimes once diabetes or hypertension or dyslipidemia is present, medications are also needed. And at the apex of the pyramid is secondary prevention, where there's already disease, or tertiary prevention, where there's a heart attack, and now you're trying to prevent that next heart attack. There oftentimes medications and procedures are necessary. Thank you very much for your attention.
Before our panel, I just want to point out I think our whole grains are complete. We made farro today. You can get this in the pasta aisle. So instead of grabbing the white pasta, go for the farro or the wheat berries or something of that like. And any recipe that you use to make pasta, you can actually substitute farro. It can be used in cold salads, as a warm dish, etc. So think about farro and whole grains next time you hit the pasta aisle. All right, so I guess I'll invite Dr. Bhatt and Bruce to the chairs. We'd love to answer any of your questions.
Thank you, Dr. Parks and Dr. Bhatt, for excellent presentation. Obviously a very complex topic. To me, and thank you, Bruce, for participating. You went through some of those slides fairly quickly, but I did notice that it didn't seem that Bruce was on any medications for the diabetes. Is that correct?
Correct.
Okay. And he had a hemoglobin A1C of like 6.8. Okay. I would recommend you check his fasting insulin level. I would get that down below 10. Put him on metformin if necessary. And for someone who's a diabetic, I would be careful of the total amount of simple sugars taken daily, certainly no more than 25 grams. Now, 1 cup of blueberries isn't very much. It's like 6 or 7 grams of fructose. But yeah, you have to treat people individually. And diabetics, this is the primary cause of your disease is the diabetes. Your body is in a constant state of inflammation. And if you can get that inflammation down, then the outlook is much better. So I'd be more aggressive with the treatment of the diabetes.
Yeah, the good news is after, and Bruce, you can attest to this, so 1 month after he instituted a mostly plant-based diet, his hemoglobin A1C came down to 6.0. His BMI went from 26 to 25, and that was just after 1 month of intervention. So so he continues on that intensive dietary approach to get his A1C down before he wishes to start on medications. Yes.
So I don't agree with this idea that we should just get diabetics A1C below 7. That's not low enough. You should get it down to the normal range. Why should it be 6.9? They have a lot of it. You have a 6.9, you have a high insulin level. Insulin triggers cytokines in your body. You have a lot of inflammation. That is the cause, the primary cause of this coronary disease.
So I'm going to ask one question that came online. And maybe all three of you can comment just very briefly from your perspective. The economic cost, what are we talking about here when it comes to as an individual level, as a person, like when you had to make the shift, was there an economic cost of shifting your diet? When you think from an individual cardiology or practice, like is there an economic cost to just how you treat? And then even from a societal perspective, Dr. Bhatt, if you can talk about what are we looking at from a sort of an economic cost here?
Sure. I mean, treatment of coronary disease is extremely expensive. Bypass surgery is a big ticket item. Bill could easily run up to $50,000, $100,000. Stenting is less expensive, but Bill could easily run up to $10,000, $15,000 for multi-vessel stenting. So, and there's a lot of coronary artery disease. So when you multiply the costs, it's pretty high. So for sure, from a societal perspective, preventing coronary artery disease would be much cheaper than treating it. But those sorts of economic models are tricky. It depends whose vantage point you're looking at, because if you're keeping people alive longer, it's not always easy to show prevention is cost effective.
Right.
From an insurer's perspective, it may not be, but from a societal and moral perspective, obviously, prevention is good. But as I also alluded to, sometimes the horse is out of the barn, and when disease is discovered, action needs to be taken. In this particular case, diabetes, multivessel disease, data do show that bypass surgery reduces mortality compared with just stenting, and presumably compared with just lifestyle and medications alone. So I think it was a reasonable thing to do, and if there were symptoms on top of it, that makes the decision easier.
I think you can hear someone from my lapel here. In our practice, we blend the two, using a traditional approach with some integrative approaches, and we would never deny Bruce. We were participants together in his decision to have coronary bypass surgery. But we're also participants together when if he's having side effects from medications or wishes to avoid medications, then we can talk about the risks and benefits and say, hey, look, if you're really, really serious about staying off meds, here's what you need to do, and we have to be 100% adherent most of the time, and let's give it a shot. And you've done a phenomenal job, Bruce, really, in turning around your life. You've been an overachiever from that standpoint. And so, there are medications that could help you from a mortality benefit if your A1C remains elevated. But right now, we'll keep going with our plan to continue the lifestyle interventions.
Did the symptoms improve after the surgery? Did any of the symptoms you described improve after the bypass?
Yes, 100%. I feel like a new person. The shortness of breath, the pressure, the anxiety, even the sleep hygiene I have, everything is better. I'm down to basically statins, and as far as
aspirin.
And aspirin a day.
I was just about to ask.
I can't. She keeps reminding me, but I do that as well. But getting back to this gentleman's comment about the diabetes, it is in my family. My sister suffers with diabetes, and there's no question that is the ghost that's chasing me. But together we've made a decision that the diet and exercise, for as long as I can go and keep ahead of this thing, it's our decision, Dr. Parks and mine, and at some point I'll probably have to be on medication, but in the meantime, watching my weight and my diet. You also spoke to the economics of the diet. It costs more to shop at Whole Foods. However, the amount of food we're cooking is actually, like, we do a lot of batch cooking on a Sunday, and we load up our fridge and freezer, and we're actually spending less ultimately on all the dinners out. So, it has really changed our lifestyle. So and when you do go out to dinner, it's scary to order off a menu. You really don't know what you're getting. You can presume that there's a lot of salt and sugar in all of it. So I tend to order a naked fish and heavy salads, and my portions on the meat proteins are very small.
And quickly to the question of the economics, there are models that allow people to follow, mostly plant-based diet on a budget. In fact, Boston Medical Center and Tulane University both have educational programs. You can look online and see videos, and they actually take you shopping and show you how to feed a family of 4 for $10. And part of it is sort of buying things when they're in season. Right now you can get cases and cases of zucchini, right? And so you sort of load up and you freeze and you batch. You go to the store and the vegetable aisle and you see what's on sale that week, and you buy extra bags. So it can be done. It does take more work, but it can be done.
Just to comment on that and the economics, and so in general, worldwide, a vegetarian or vegan diet is going to be cheaper than a meat-based diet. In fact, some parts of the world are vegetarian, not necessarily even for any particular choice other than economics. So Whole Foods, of course, there's a markup for that type of, specialty type store. But in general, taking that aspect out, a vegetarian or vegan diet would be expected to going to be cheaper than a meat-based diet.
Full of everyone's time, and given
even for any
this has been, as you can tell, a very rich.
Whole Foods, of
take a quick moment to just really thank our patient Bruce. Thank Dr. Parks for just leading this wonderful and spearheading this dialogue, and thank you, Dr. Bhatt, for really keeping this really in a balanced perspective. We have plenty of time for discussion. It's just that we have to also vacate the auditorium. So please join us, and I hope some of the speakers will and Bruce is willing to stick around just for a little bit to enjoy some refreshments just across the hall, and you may get some little more intimate time. But again, thank you to everyone for coming. We invite you to come next month, Tuesday, September 10th. Again, here at 8 a.m. For a topic led by Dr. Vitaly Napadau. And if you haven't signed in, please do sign in so that you can be included on our mailing list as well as get credit. So again, thank you, everyone. Thank you.
Thank you.
Great.
Thank you.